Assalamu alaikum wa rahmatullahi wa barakatuh, everyone. Hope everyone's doing well. Welcome to this panel session on male physiology and testosterone. To people who I kind of like met before last year, great to see you guys back. Hope you guys had a great vacation. And to anyone who kind of like doesn't know who I am, my name is Abdelrafour. Usually just go by Abdel. I'm currently like an intern, so like about to like finish my journey. But I had a blast last year in PAL, and I'm really love this new leadership. So I'm really excited about how things are going to turn around. And yeah, this is a bit different from like my main interest. I'm mainly I'm mainly interested in like ortho and bones, but this is kind of like close enough. Um, Male repro anatomy and physiology, and in that second year topic, back in my time, I like during my first pass through this material, I kind of was not 100% confident about it. But later on, I realized, hey, I really like it's a very nice system because it is very logical, it's very systematic. And the beauty of both the male and the female reproductive system is there's so much overlap between the two. So today it's basically going to be going over two different like topics or two different lectures. You have the male reproductive anatomy and physiology, and you have testosterone. Now, when you look at the contents, you will notice I kind of shuffled things around. Now, usually I think you guys were taught, like you guys were given like male sex differentiation first. I do not like this approach. I think it's better to understand the anatomy really well and understand the anatomy and the physiology, and then we add on the embryology later on because it makes it so much easier. And then we're gonna like kind of like wrap up by speaking about testosterone and like the clinical like applications of that. So without any further ado, let's start with a little quick cheeky introduction to get the ball rolling. So the reproductive system is kind of interesting because it's not really needed for the survival of an individual. It is crucial for the survival of a species, but individually speaking, you won't die if you don't spread your genes technically. And the whole idea of the reproductive system is basically that, the idea of passing your genetic material to the next generation. Whenever I look at the reproductive system, honestly, I kind of like mentally organize it into like made up of three main components. You have the gonads, you have the hormones, the reproductive hormones. Then you have what I like to call wingman type stuff, right? This is going to be accessory type organs. Um, Beginning with the gonads is just the scientific name of saying, hey, these are sex organs, organs that are responsible for sex. And a sex organ, the beauty of the reproductive system is a lot of times it's the same thing, it's just named differently in males and females. So the male gonads are what we know as testes, and the female gonads are what we call ovaries. Now, these sex organs, their job is to contain a lot of cells that we call sex cells. But that's just not really like the most professional term. So we chose the word gametes. The whole concept of gametes is this: the human body is made up of a bunch of somatic cells, and each somatic cell has like 46 chromosomes, right? It's vibing. If we wanted to create a new person, a new human being, we cannot let two like somatic cells merge and fuse because there's going to be simply way too many chromosomes. So the whole concept of a sex cell or a gamete is a cell that has half the normal number of chromosomes. So these are cells that their job is to find the opposite gender's kind of like cell, the equivalent, and then just merge, and then you have a new baby. So like for males, that's going to be sperm, and for females, that's going to be ovum. And both sperm and ovum have 23 chromosomes. But when they fuse, when they merge, suddenly it becomes 46, which is the exact same number as a somatic cell. Therefore, like a human person or like a human life is basically formed from this like combination. Thirdly, we have hormones. There's a lot of important things about reproductive hormones. In general, just remember, most of them are cholesterol derivatives. In order to make them, you take cholesterol and you just do like a bunch of like magic, and they end up like turning into the reproductive hormones that are important, as we're going to see later on. So one thing it is very important to know, because cholesterol is not soluble in plasma, it doesn't like it won't be able to just like dissolve in plasma. We need these like proteins or globulins that bind into them so they can be transported within the blood system. And because like our hormones are cholesterol derivatives, they have the same properties as cholesterol. They are also poorly soluble in plasma. Therefore, you cannot have like testosterone just flowing through your body. It is mainly going to be like bound to a protein, and that's going to be relevant later on when we go over like the mechanics of testosterone. Now, these hormones are very important because they are like crucial in the development of reproductive organs. So that basically saying, hey, these hormones are important in embryology, as well as they're important in the function of other organs and also libido. The whole concept of sexual drive, it doesn't come out of nowhere. It is hormone dependent. So in males, we have them in both, but like the primary hormone that we're gonna talk about is androgens, like testosterone. But also don't forget, we also have other hormones like estrogen and progesterone, etc. And that's again just to recap this kind of stuff. The wingman stuff, you're gonna see this when we move on towards the anatomy and the function of the male reproductive system. Now, when we approach, like one thing you will notice whenever we approach male or female reproductive systems, you can classify the structures as either being internal or external. And it's really like very, very intuitive, right? This is a picture of a male reproductive system. You can see how there's a bunch of stuff inside the body, and there's some stuff that's like sticking out. That sticking out portion is what we call the external genital tract. And the stuff which is kind of inside the body, we like to call it the internal genital tract. And that's a nice way to kind of like stay organized. So we're gonna move on by saying, okay, within the internal genitalia, what we're gonna really focus on today are like the testes, something called the vas deferens, something called the epididymis, something called seminal vesicles, some other like random stuff. And for external genitalia, mainly we're gonna be speaking about the penis, the scrotum, and the penile urethra, kind of, but not really. So the way how I like to approach the internal genital tract is to basically swim up. Like for a second, I want to like take you on a journey where we're following basically a sperm as it goes up from the testes and out of the body. And as we're following along, we can explore the anatomy of each section. And this diagram here from first aid is very nice because it kind of like shows you this mnemonic of how everything goes. You start from the seminiferous tubules, and they will all go and go and go and drain into something called the epididymis. From the epididymis, they will go to something called the vas deferens. Then from the vas deferens, they're gonna meet up with something called the ejaculatory ducts, and then they're gonna like go through the urethra, go through the penis, and then outside the body. So let's begin by speaking about something called a seminiferous tubule. This is like, think of it as the functional unit of the testes. And the seminiferous tubules are like primarily composed of two very, very important cells. The first one is going to be called a Sertoli cell, and the second one is going to be called a Leydig cell. And they work together. They do a lot of cool shit that we're going to explore later on. So we start with this kind of like diagram. It looks bad. It looks disgusting. It looks overwhelming. But what I want to show you is just like the basic function. And if we're looking at the image on the left, you see that this seminiferous tubule is basically a tube, right? It's a tube. Within this tube, you have a lumen or an empty space, and the wall of that tube is made up of two kind of cells: the Sertoli cells and then the sperm cells, like the spermatogonium, spermatozoa, and they kind of like exist between the two Sertoli cells, right? Outside the seminiferous tubules, just like vibing on the side, is something we call the Leydig cell. And we're going to explore their function and everything. But before I dive into that, I want to introduce a very important concept. Sperm are immunogenic. Sperm are immunogenic. Sperm should never ever be exposed to the bloodstream because the bloodstream is like, it's jam packed with a bunch of like immune cells, right? And these immune cells are, if they interact with sperm, they're gonna initiate an immune response, and the body will destroy the sperm. So we call and this is not really part of your lectures, but I'm just gonna tell you from now. There are some certain sites in the body, we call them immune privilege sites. One of them is the testes. So in order for me to prevent sperm from mixing from blood, I need to create a blood testes barrier, right? That would like fix the problem. And that's exactly what's going on in these seminiferous tubules. If you look at the image to the right, you have a basement membrane. And on that basement membrane, you have those Sertoli cells. Between two Sertoli cells, you have these tight junctions, right? So the sperm cells, as they're developing from the base, like next to the basement membrane, they are never going to be exposed to the bloodstream because those Sertoli cells prevent them from escaping and from leaving. So the only way they can kind of like mature is they start maturing towards the lumen, not towards the basement membrane. And like the clinical like relevance of this is sometimes you may have someone who is presenting to your clinic with like infertility, and you find out they had history of testicular trauma a while back, and their immune system is absolutely annihilating this like the sperm cells. So that's potentially a cause of like infertility. Now, moving on to the Sertoli cells, their functions, we spoke about one of their functions, right? Formation of the blood-testis barrier by these super duper like tight junctions. But the Sertoli cells do other stuff. They support something called spermatogenesis. Like sperm cells, they develop and eventually they become the sperm that we kind of like are very familiar with, but that's a process, right? Sertoli cells support that process. They support something called spermiation. And spermiation, just like I said, the way how the sperm cells are like swimming towards the lumen, that process of them going from stuck between two Sertoli cells to suddenly being, hey, I'm in the lumen, that's called spermiation. And the Sertoli cells like really help with that a lot. Also, they do something very important. They can concentrate testosterone. How is that? Earlier, I told you that testosterone is an example of an androgen. And an androgen is an example of a reproductive hormone. And a reproductive hormone is a cholesterol derivative, right? So these cholesterol derivatives are like bound with these proteins. And the Sertoli cells, what they do is they produce a bunch of that protein. So you're concentrating the testosterone, which is really important because in order to make sperm, you need testosterone. Just remember this concept. Another thing is the production of inhibin. That is gonna play a role later on when we speak about the feedback mechanism of like testosterone production. But for now, remember, one of the roles of the Sertoli cells is to produce inhibin. Another thing they do is they produce anti-Müllerian hormone. And I'm not even going to speak about this now because it's only really relevant when it comes to embryogenesis. Then we have the Leydig cell, and the Leydig cell just like literally produces testosterone. That's the function of the Leydig cell. This disgusting image here is like some biochemistry nonsense about, oh, how cholesterol is turned into a bunch of stuff. And I just want you to know that that first step of transforming cholesterol into pregnenolone, I don't know how to pronounce it, but whatever. It's this key step is basically catalyzed by Leydig cells. And that's why we say Leydig cells' job is to produce testosterone. Another very interesting thing to know in the male reproductive system is testosterone is like important, true, but we have a very powerful and potent form of testosterone called dihydrotestosterone. And that is basically very important when we're gonna start exploring embryogenesis. But just want you to know that this is one of the fates of testosterone. But that requires an enzyme called 5-alpha reductase. Going back again, resuming the concept, the anatomy of the seminiferous tubules, this is a very simple schematic. You have a seminiferous tubule, you have the what do you call it? The Sertoli cells forming your blood testis barrier, sitting on the basement membrane, and you have a lumen. And surrounding the seminiferous tubules in the basement, like in the extracellular space, you have a bunch of Leydig cells, and they're producing a little bit of testosterone, a little bit of testosterone, a little bit of testosterone, right? But we want that testosterone mainly to be inside the seminiferous tubules because we want that testosterone to go into sperm production. So what we do is the Sertoli cells produce something called androgen binding globulins. And that's how we concentrate testosterone within the seminiferous tubules. And that's how we have sperm production. So that's all good. But like as I'm sure you guys are very, very familiar by now, one of the very crucial aspects of the endocrine system in general is the pituitary. There's this higher level of control. So the big question is, what's the role of the pituitary in all of this? So the anterior pituitary gland secretes two very important hormones, LH and FSH, and both of them have an impact on this whole like cycle. So LH, L for L, will go and activate Leydig cells, and Leydig cells' job is to produce testosterone. And FSH will go to the Sertoli cells and tell them, hey, increase spermatogenesis, increase the amount of androgen binding globulins that you're making so we can concentrate even more testosterone, stuff like that. So if I want to make more sperm for whatever reason, the hypothalamus will start secreting these pulsatile GnRH secretions to the anterior pituitary. The anterior pituitary will be like, oh, okay, bet, boom, LH and FSH is being produced now. The LH will go to the Leydig cells, testosterone production will increase. FSH will be like, yo, like Sertoli cells produce more ABG, androgen binding globulins, and then you have higher concentration of testosterone within the seminiferous tubules, and then boom, you basically have more sperm. And this image from your slides just demonstrate exactly what we said, just like in italics. The Leydig cells again have receptors for LH, so when LH binds, it basically increases the conversion of cholesterol to pregnenolone, and that basically becomes testosterone. And then FSH will go down to the Sertoli cell and begin to produce a lot more androgen binding globulins, so we can like basically concentrate that testosterone. And I'm repeating it a few times just to really like cement this concept of this idea. So we reached our first ever checkpoint. So this is my opportunity to ask you guys if you have any questions so far. No questions, I'm gonna assume. Okay, perfect. So we're done with the testicles, kind of like we now, like it's really the seminiferous tubules is done. It's time to move on to the next structure, which is the epididymis. Now, here's like an image. You can see the testes there. And obviously in this image, you can't really see them all magnified, but that epididymis is this kind of like, I don't know, it's like a snake wrapping around like an egg. It's like the head of that snake, right? It is this like swelling on the top. And that is basically just all the seminiferous tubules of the testes draining into the epididymis. And like just when you look at this diagram, you notice how this testes is surrounded by something. It's a thick connective tissue capsule called the tunica albuginea. You can see that there's like septation. So you have these like lobules type, and they just all drain into the epididymis, right? So what exactly is the epididymis and why do we care so much? So the whole concept is these sperm, when they're being made in the seminiferous tubules, they're like, I'm gonna be real with you, it's probably not the most like chill environment. Let's go chill in the epididymis. This is a chilling zone for sperm. They go there for like up to 20 days. They chill, they relax, and there they basically get some modifications. The first modification is they get motility. They basically get that tail. They are able to move around more. The environment there is very acidic, high pH, like low pH, like a good bunch of H plus ions there. So they basically mature. And then when the time is right, when the guy basically wants to got the name. When someone wants to release sperm, when someone wants to ejaculate, my bad. When someone wants to ejaculate, the epididymis itself will contract and squeeze all those little spermlings into the next structure, which is the vas deferens. Now you basically have one vas deferens, and it's just like going up from the scrotum, like from the external and swimming towards the body, loops around the pubic symphysis. And the main job of the vas deferens, it is just a conduit. It is just a passage. One kind of like clinical anatomy, like one clinical like relation. This is what a vasectomy is. A vasectomy, you just snip the vas deferens, so all that sperm cannot reach the penis. That's the whole concept of vasectomies. There also they basically meet with something called an ejaculatory duct. And remember how I mentioned early on we have these wingman like structures. One of these wingman structures is the ejaculatory duct. So they get extra fluid. They get pumped up with a lot of fluid that makes like those sperm basically begin to turn into semen. Right, goes from like these cells into like fluid. So that's the vas deferens, right? These accessory glands, these wingman organs in the male reproductive system, there's three main ones. You have the prostate, which everyone like is, I'm pretty sure, very well aware of. But these other two are kind of like unfamiliar, right? The seminal vesicles and the bulbourethral glands. Now, the seminal vesicles is the first one because, and I'm going to mention it first because it's the first one to meet up with the vas deferens. Its job is to basically modify and add some cool stuff, right? So the first thing it does, it adds something called fructose. Which the way how I imagine it is these sperm, bro, they moving around, they consuming a lot of energy. You want to give them a lot of like a juice filled drink, and that's what fructose is all about. They also give you something called vesiculase. Now, vesiculase is very important because it helps coagulate sperm. And you may ask like, hey, why would you want semen to coagulate? The whole concept is, and that will make more sense during like when we speak about the male sex act, is you don't want all that semen to just like dribble out. You kind of want it to stay within the vagina, and that is done by coagulation. And when you look at the components of like what semen is, over 70% of the volume comes from these seminal vesicles. So the vas deferens, basically those vesicles drain a lot of fluid into the vas deferens. And then we meet up the next structure, which is the prostate. Now the prostate encircles around the urethra, right? It secretes a lot of stuff that will activate sperm, stuff like fibrinolysin, which is very important because later on, you don't want the sperm to be coagulated forever. You just want it to be coagulated for a while, and then you want something to break down to allow the sperm to swim all the way up the uterus into like the fallopian tube. And this is where the prostate comes in because they add something called fibrinolysin. And fibrinolysin's job is like the exact opposite of vesiculase. Its job is to freeze the sperm in the semen. So that's the second accessory gland. Then you have the bulbourethral glands, which is like, again, draining now into the urethra. The vas deferens, after it passes the bulbourethral gland, is now called the urethra. And the job of those glands is to create lubrication. It allows the secretion of a lubrication fluid, which actually happens before ejaculation. I think the colloquial term for this is like pre-cum. The whole concept of that is that it lubricates the penis, and to a certain extent, the female has a very similar phenomena where there's also bulbourethral glands in the vagina, which will lubricate the vagina. So the main function of the bulbourethral glands is going to be lubrication. Now, just to kind of like connect everything we've talked about so far, let's look at semen and like kind of explore like more about the contents, right? When we think semen, a lot of times we think sperm, but actually only 10% of semen is actually sperm. Then the rest, 90%, is all those accessory gland fluids. Fructose from the seminal vesicles, prostaglandins from there also. And the whole idea of prostaglandins, it helps induce contraction of smooth muscle, which again will become very important later on when we speak about ejaculation. You also have those clotting factors like vesiculase that is secreted by the seminal vesicles to coagulate. And you also have fibrinolysin from the prostate to break down after ejaculation. So that was the internal genital tract. Just kind of continue with the flow. Again, following up that sperm, it's going down the urethra. It's eventually going to go into the two main kind of like structures I want to talk about. That's going to be the penis and by extension, the scrotum. One thing, and this is like really random, on it, like honestly, the only thing about histology which I find genuinely like goofy is all those penile cross sections in histology. They always look so like, I don't know how to describe it, bro. It's just goofy. Okay. But whenever you see this diagram, and it's very, very classic kind of like cross section that you can see many times, it's one of those things you know immediately that this is a penile cross section. Now, the penis anatomy is basically a collection of two types of spongy like connective tissue network. It's very spongy, it's very kind of like filled with a lot of blood vessels, and it's gonna make sense why, because the whole concept of the penis is an external structure that gets hard. And the way how this process happens is through blood vessels, through blood flow. In order for this to work, we have something called the corpora cavernosa. It's the eyes of the goofy face. When you go up there, when you see those two eyes, that's the corpora cavernosa. And going right between them, making like the pupil, is the cavernosal artery. The mouth is made by something called the corpus spongiosum, and the little smiley face that you see, just like meow, smiley, that's the urethra. So the urethra is basically embedded within the corpora cavernosa, and then you basically have the other two like dual like corpora cavernosa. Now, the whole idea again, it's the same thing. The urethra is going to be, so the penis itself is a conduit. It's basically like the motorway for urine to leave the body and for semen to leave the body. It's pretty simple. And obviously, as you can tell from the image, the scrotum's main job here is temperature regulation. Now, the very interesting thing is and we're gonna go over this again when we go over embryology, but initially, okay, the gonads are in the abdomen. The testes are in the abdomen, but the abdomen is just too hot of an environment. So the testes are like, you know what? I'm done. And they just migrate out and literally leave the body. And the scrotum kind of plays a very important role because we want those testicles to be as cold as possible, not as cold as possible, but to be in that perfect environment for sperm production. So the scrotum obviously is the outer layer, this like bag-like structure that holds the testicle and the epididymis and all the seminal vesicles and a lot of stuff, honestly. but their main job is for thermogenesis, to keep the testicles cool. You have something called a cremasteric muscle, and the cremasteric muscle is a muscle that pulls the testicle upwards, and it's actually something that we test a lot when we are assessing a patient's neurological status. So last month I was in trauma surgery, and a lot of times we'll get patients who had like insanely bad car crashes, they are intubated, they have like brain damage, and we want to assess, hey, how much damage does this patient have on like the lower spinal cord? So a lot of times what we do is we assess the cremasteric reflex. The cremasteric reflex, you simply stroke someone's inner thigh and you will notice the balls basically go up. This is the cremasteric reflex, and it's a good indicator of, hey, how good is the innervation down there? You also have something called the dartus muscle, which wrinkles the scrotum, as you can see up there. This is the dartus muscle. Obviously, it's not the dartus muscle. It's not scrotum, but like you get the point. It makes it all very, very wrinkly. And if you notice, I mean, obviously for the guys here, when it's a very hot summer day, okay, when it's like a really warm environment, the scrotum is not very wrinkly. It's very loose to allow for heat loss. But when it's a cold environment, or when you just come out of like a cold bath or a cold shower, it's all like shriveled up, and that's due to the dartus muscle doing its job. And the scrotum in general is supplied by blood vessels that are carried within the spermatic cord that gives you like the blood supply. So we just went through a whole bunch of stuff. Went through the male, internal, and now we just finished with the external genital tract. Again, as always, this is a checkpoint if anyone has any questions. Perfect. So moving on. Now, again, we went through the anatomy, and the anatomy is very important because it helps us build into the physiology, right? And the whole point of, again, ultimately speaking, the main point of a penis is for sex. So when we look at, there's three main phases of the physiology of sex in from the perspective of a male. You have erection, emission, and ejaculation. Let's start with obviously the most important concept, right? The penis has to get hard. And if you ask why, it is simply because you want to be able to decrease the distance, okay, from the cervix for the semen to go into. The longer the distance, like from a logical perspective, if someone is not hard, you are making it much harder for the process of penetration. So in order for us to basically have a boner, it's all about blood reaching the corpora. Remember how I told you before that the penis is basically just this like corpora spongiosum and it's corpora cavernosa, and it's like this like smooth muscle, like very trabeculated, spongy network filled with blood vessels. Yeah, the whole concept is whenever we want someone to get hard, is to have like blood fill up the penis. That's why the whole phrase that, hey, the blood is like you're thinking from like the blood is like not reaching your brain, because literally what happens when you get a boner is blood like begins to enter the penis and engorges it and makes it very, very hard. So that's the whole like concept behind it. Now, in order for us to increase the amount of blood reaching those like spongiosum, we need to vasodilate the smooth muscle cells of those blood vessels, right? Because when those smooth muscle cells relax, the blood vessel will dilate and more blood will enter. That's the whole concept. And the secret ingredient for this relaxation is something called CGMP. Now, CGMP I want you to think of it as a muscle relaxer. It will relax the smooth muscle cells. It will allow for vasodilation. Vasodilation will go and fill up the penis with blood. And again, it's the same concept. Some sort of sexual stimuli, or sometimes, as I'm sure many of the guys here are familiar with, sometimes without a sexual stimuli, just like that, for some reason, you have activation of the parasympathetics. So this is very important. In order for you to kind of get hard, it's more of a parasympathetic response. People do not tend to get hard in like fight or flight responses. That's gonna be a mechanical kind of like disadvantage. So it is one of the rest and digest pathways. So it is activation of the parasympathetics. The parasympathetics will release nitrous oxide. Nitrous oxide is another dilator. It will increase the amount of CGMP within smooth muscle. And we said CGMP is a vasodilator. So you have a lot of blood filling up the spongy network, and boom, you have an erection. And the reason why I bring this up, and it's so important, is because one of the drugs that changed society so much is Viagra. And I say this because a lot of times, and this is something you will notice a lot when you start doing your clinical rotations, You will have patients, male patients, sorry, who will not go to the family physician for many, many health reasons. And this was something taught to me by one of my seniors when I was in second year. Apparently, a lot of guys, especially older guys, don't go to the doctors often. They could have like triple vessel disease and they'll be suffering, and they have diabetes and hypertension, and they have these random pains and they have back pains, but they won't go to a doctor. The moment they can't get an erection, they're booking that first appointment. So this is a very, very high yield topic that is frequently tested and assessed in STEPS exams, and it's the mechanism of Viagra. If we know that CGMP is the muscle relaxer, we know that CGMP is not going to last forever within the smooth muscle cell. There's something called a phosphodiesterase, or a type 5 phosphodiesterase, that breaks down CGMP and prevents like the relaxation for going on for too long. Viagra inhibits the inhibitor. So what Viagra does, or sildenafil, the actual name, will inhibit the breakdown of CGMP. So you basically prolong the relaxation of smooth muscle cells. You prolong the process of vasodilation. So you basically get harder and for longer. That's the whole mechanism of Viagra. So, okay, not obvious, not I, but like someone gets a boner. What's next? We have like the erection stage done. Now we have something called emission and ejaculation, and it's really confusing, right? Like, what's the difference? Is it not the same thing? Well, actually, surprisingly, it's not. So going back to the functional anatomy, we said the site of being chilling for a sperm is the epididymis. They're there, they're chilling there for like 20 days. They're basically out there like getting like matured and getting the ability to be motile. But the moment we need to like ejaculate, this is when we have the first phase of emission. Now, emission is contraction of the epididymis and the vas deferens, and it will basically squeeze the sperm into the urethra. And this is a sympathetic response. It is not a parasympathetic, it is a sympathetic response. The process of getting an erection is parasympathetic. The process of this smooth muscle contraction is sympathetic. And at the same time, when that happens, we have something called an internal urethral sphincter. And that internal urethral sphincter contracts. And it's very important we contract because we do not want retrograde ejaculation. And by the way, for the future, guys, whenever you hear the word retrograde, it just means the backwards flow of fluids, like semen in this case. We don't want semen to end up in the bladder. That's really not optimal. We want all the semen to go out. So during emission, you have contraction of the internal urethral sphincter, and you have contraction of the epididymis and the vas deferens to basically squeeze the sperm all the way up into the urethra. And finally, the last step, which is ejaculation, is the expulsion of semen from the urethra into the rest of the body, right? And this is now, again, a parasympathetic response. It is that rhythmic contraction of the corpus spongiosum. And again, why am I mentioning corpus spongiosum? Because if you remember the goofy ass histology photo way back, and I mentioned it's important because the corpora spongiosum, which makes a smiley face, right, is where the urethra is. So that muscle will contract to squeeze out all the semen out of the penis and into like the final destination. So when you look at the life cycle of sex, you have erection and emission and ejaculation are kind of very similar. So I kind of lump them together, but that's the 3 steps of sex. Now, there is something called the sexual response, okay? And it's mentioned in the slide, so I'm only introducing it for the sake of completion. But I'll be honest with you, I do not ever recall seeing this. It never came up at all. It's like very low yield outside of uni, but I know uni brings up some like what's low yield in real life is probably like high yield in exams. So here it's the concept, it's a physiological breakdown of sex in general. You have something called an excitement phase. Then you have a plateau, then an orgasm and resolution. The excitement phase corresponds to the erection stage that we mentioned early on. So you basically, like your arousal increases, you get erect, then you'll have an increase in heart rate and blood pressure. You're getting really excited, and your body is like preparing for like, you know, the orgasm. And then emission and ejaculation happens usually during the orgasm phase, and then you have the resolution. And then again, you go into like a little bit of a refractory period, and then you can resume again. So that's kind of like the anatomy and the physiology all together, going over how sex works and all the various stages. Anyone has any questions so far? Okay, I'm assuming no, so I'm gonna move right on because it's a Thursday. So now we move on to one of my favorite topics, just because it's so high yield in step one. It was so high yield in step two. I'm gonna be a bit cocky and I'll tell you, I really love those questions mainly because I get them right, because I kind of like figured out the system, and it's because the system is extremely logical, and it all begins with one little cheeky bugger called the Y chromosome, and that does everything. But before we move on to how a person becomes a male, and I'm, you know, with a male with an asterisk in between, I want to introduce a very important concept. And the girls are going to really love this one. The initial template for all human life is female. If nothing happens, we would all be female. It is the addition of the Y chromosome that makes me and the fellow guys here into the people that society really loves. Okay, men. And the main reason for that is because initially we all had what we call a primitive gonad, and all primitive gonads by default are going to become an ovary. However, so let's use like an initial template. Imagine someone does not have the annoying ass Y chromosome. They're gonna have a primitive gonad. The default template is turn that into an ovary. The ovary is gonna produce estrogen, and this is also gonna help produce something called the Mullerian duct, right? That estradiol, that estrogen is gonna be very important in producing the female external genitalia. And really, the beautiful nature of the reproductive system is for both boys and girls. A lot of them have shared function and shared similarity. What I mean by this is there's a lot of equivalence. The ovary in females is the testes in males. The penis in males is the clitoris in females, because they're both erectile tissue. And if you take a female and you give her a lot of testosterone, that clitoris will enlarge, and it may actually mimic a penis, because they are basically the same structure, just in different kind of like templates. The same concept with the scrotum. The scrotum is basically the labia. You have the vagina is very similar to, I forgot the anatomy honestly, but there's a lot of similarities. So the presence of estrogen is very important to have the female external genitalia, which is the vagina, the labia majora, the labia minora, the vestibule, all that. The Mullerian duct, however, is going to give you the internal genitalia, which is the uterus, the fallopian tubes, that kind of structure. So this is the pathway if someone is normal and has an XX chromosome. But sometimes some people are born with a Y chromosome. And in that little Y chromosome, that little small chromosome, is a gene called the SRY gene. Now, the SRY gene produces a gene product, a transcription product that goes into the gonad and goes like, yo, don't turn into the ovaries. Can you turn into the testes, please? And the gonad goes, yeah, sure. Turns into the testes. Now, the testes, as we said previously, and that's the reason why I reshuffled the lecture, is made up of Sertoli cells and Leydig cells. And we know the Sertoli cells' job and the Leydig cells' job from previously, right? I mentioned way early on that one of the functions of the Sertoli cells is the production of an anti-Mullerian hormone. Now, this anti-Mullerian hormone's job is to break down and disintegrate the Mullerian duct. So the main function of the Sertoli cells during this kind of like primitive embryogenesis is to make sure that this baby boy does not have a uterus and does not have a fallopian tube and does not have any of the female internal genital tract. Then you have the Leydig cells, and the Leydig cells, as always, they produce testosterone. Now, testosterone is very important because it allows us to form the Wolffian duct, which gives us the internal genital tract. So think of the epididymis, the vas deferens, all that good stuff. This is all made by the Wolffian duct. Now, also early on, I mentioned how testosterone is also converted into a very more active and potent form, right? The 5-dihydrotestosterone, or DHT. Now, DHT is important because it allows us to develop the external genital tract, which is going to be the penis, right? It's going to be the scrotum. So what happens is, let's say, lo samahallah, someone does not have that enzyme. Someone has a 5-alpha reductase deficiency. Yeah, they will have testes. Yeah, they will have an epididymis. Yeah, they will have a vas deferens because they have testosterone. The Wolffian duct is still formed. But when you look at them at birth, you'll be confused. You'll be like, hey, I don't really see a penis. It looks a lot like a vagina, but really it's just because they are not exposed to DHT, which is important for the external genital tract. And now I want to tie this all in with a bit of like clinical pathology. There's something called androgen insensitivity syndrome, right? This is a 46XY chromosome person, but they're female. Let me explain. Imagine you are now a family medicine doctor and you're in clinic, and this girl comes into your clinic with her mother. She is like 17, and the mother's complaining, hey, she never had her period, like at all. I got my period when I was 14, but she doesn't have it. And like no one in my family, like none of her aunts or her older sister has like delayed menarche. What's going on, doctor? So you're like, primary amenorrhea, we're gonna do a physical examination. Do a physical examination, it's a female, right? What you see, and I use this image of Hannah Gaby Adil. She's a Belgian model, okay? So imagine her coming into your clinic. Externally, she's a female. She has breasts, she has a vagina, okay? She has always been a girl, okay? But when you do a workup to see, hey, is there a problem with the uterus? You pull out your ultrasound, you notice there is no uterus on ultrasound. And when you look at the examination, you find two masses in her labia majora. And you do a chromosome analysis and you find that this girl is actually biologically a guy. It's a 46XY chromosome. What is going on? In this particular case, this is an example of a disease or a condition called androgen insensitivity, right? Androgen insensitivity syndrome. Here, the problem is with the androgen receptors. The body is not able to detect testosterone and is not able to detect the presence of DHT. So these patients are born with the Y chromosome, the 46XY. That Y chromosome has the SRY gene. So what happens is the gonads become testes. So she has testicles. These testicles contain Sertoli cells and Leydig cells. The Sertoli cells will produce anti-Mullerian hormone and they will break down the Mullerian duct. So she won't have a uterus, she won't have a fallopian tube, she won't have any of the female internal genital tract. Now, the Leydig cells are producing a lot of testosterone, but that testosterone is not being detected by the body because there's a problem with the receptor. So what happens is you don't have a Wolffian duct. So you don't have a male internal genital tract. You only have a testes, but you don't have a vas deferens, you don't have an epididymis, you don't have any of that. And because now there is no DHT, the template, the usual template for the external tract is going to be female. So she is going to live her whole life being a girl until she will initially present with, hey, why do I not have a period? And then you'll find out much later on that, hey, you actually have androgen insensitivity syndrome. And that's exactly what this the Hannah Gaby Odile, she is an example of a famous person kind of model who has AIS. Technically speaking, she is 46XY, but when you look at her, she does look like a guy. She looks like a girl. So that's a clinical correlation with the whole kind of like male sex differentiation. There's also 5-alpha reductase deficiency. I think it's more for third-year topics. I didn't bring it up, but it's also the same kind of like concept. So that was a lot. Any questions so far? And if anyone is interested, I guess these are like colloquially we call these people like intersex, I believe. Their management, if anyone's intrigued, is usually more about gender affirming care. After they like find out that they are like 46XY, they kind of have a decision on like deciding whether like to identify as a guy or a girl. And a lot of times they continue to identify as a girl. So there are certain things we can do. And the labial masses that I mentioned early on, these are basically the testicles, right? These are the two masses. So usually what we do is we remove the testicles because we don't want them to become cancerous because we don't want to keep them. And then maybe we can do like a vaginoplasty, make the vagina a bit longer, make it more comfortable for them. It's really more of like supportive care. Okay. I'm assuming no questions. Perfect. We're nearly done, by the way. Testosterone physiology. Okay, so you're gonna hear this a lot. Something called the hypothalamic pituitary gonadal axis, and I really love the name so much because it's literally in the name. It's a connection between the hypothalamus, the pituitary gland, and the gonads. In males, we've already kind of like explored this. It's the hypothalamus secreting the GnRH to the anterior pituitary, which then secretes LH and FSH, and that will go and either increase testosterone production via the Leydig cells or FSH by the Sertoli cells. This is kind of like the same diagram from your slides, and it's a bit more complicated, but it's literally the same thing. What you're just seeing now is the negative feedback inhibition. Like obviously testosterone, if you have a lot of it, it will go and inhibit the release of GnRH. Also, we said that one of the roles of the Sertoli cells is the production of inhibin. Inhibin will go and inhibit the anterior pituitary, so decreasing the amount of like, testosterone being produced. That's kind of like the general idea of the slide. And one thing you have to really, really understand is that the release of GnRH from the hypothalamus is pulsatile. It is not this constant secretion. It basically goes up and down. If you give someone a constant amount of GnRH, you are going to completely shut down the LH and FSH spikes. And actually, you're going to find this out much later on, but that's something we do on purpose to treat some certain conditions. We give them continuous GnRH, which shuts down the LH spikes. Now, constant, again, this is the same thing. Constant GnRH release would lead to no LH secretion. Now, puberty begins when we have the onset of pulsatile GnRH release. It begins pre-puberty, and you can see this nice image there. Before puberty, just before puberty, you start to have the sleep-induced GnRH release, right? Your GnRH begins to start like pulsatile secreting at night, but puberty is when you start having that very, very classic pulsatile secretion. That's what really triggers the transition from childhood to adulthood. It's that LH and FSH spikes in girls, that this is what's going to induce breast production, breast development. It's what's going to like stimulate ovulation. It's what's going to stimulate like periods. In guys, that's what's going to stimulate like penis enlargement, testicle enlargement, etc. This is very, very important. And I really want to focus, because this topic is male repro, I want you to focus on the bottom like image. This is something called Tanner staging. Tanner staging is the way for us to determine someone's sexual maturity based on how they look. And it's important because if you have someone who's 17, when you look at their penis, for example, it's like stage 1 or stage 2, you kind of like know something is kind of wrong, right? Because usually this is how like this is their sexual maturity at a different age. So that's the main idea, and you can see how it's different throughout. It's just called Tanner staging, and you will hear about this later on, especially in clinical years. We'll be like, hey, patient is coming in, she is presenting with like she never had a period, and she's like Tanner stage 4, and you're like, that's weird. Like she should be having a period now, you know? Or someone who is like 7 years old and she's Tanner stage 3, or he's like 6 years old and he has like Tanner stage 4, he has hair in his pubis, he has precocious puberty, he's getting his puberty much before normal. It's kind of very important in approaching patients later on who have puberty related conditions. But anyway, back to that beautiful hypothalamic pituitary gonadal axis. Again, this is kind of like the same structure that we kind of went through, right? And this is where the inhibition and the feedback inhibition kicks in. The Sertoli cells produce inhibin and follistatin, which inhibits the anterior pituitary, and they produce something called activin, which increases the activation of the anterior pituitary. So they will either decrease further testosterone production or do the exact opposite. Now, testosterone is created by, as we said, Leydig cells under the influence of LH because they have an LH receptor. And as we said, that the first thing that happens in the Leydig cells is the conversion of cholesterol into pregnenolone or pregnenolone. I don't know how to pronounce it. But that first step is done by the Leydig cells by activation of this STAR enzyme. It basically allows the cholesterol to get squeezed into the mitochondria where it gets broken down. Now, testosterone in general has basically 3 fates, right? The first fate is on its own, testosterone can do a lot of shit in the body, okay? Testosterone has a lot of effects on peripheral tissue. One of the fates of testosterone is to be converted into estrogen via the enzyme aromatase. So aromatase will convert that and it will turn into estrogen, which is important for a lot of things in the body. So even guys have estrogen. Everyone has testosterone, everyone has an estrogen, we just have it in different quantities. And the third fate that we spoke about before is the conversion of testosterone into its more active component, which is dihydrotestosterone via the enzyme 5-alpha reductase. Now, DHT has strong secondary sexual characteristics, is very important for the development of a deep voice, is very important for the development of prostate growth, it's very important for the development of penis growth, etc. Okay, it's what's really gonna give you that like external genital tract. It's really what's gonna make you look like a guy by having a big penis or wherever. معلش 20 دقيقة الله يسلمك 20 دقيقة مكفرين دحين um oh Okay, sorry about that for the little brief disruption. So as I was saying, the whole kind of like concept of DHT is critical for the development of like secondary sexual characteristics. Okay, so that's the whole idea of like having a deeper voice, the growth and development of the prostate, etc. Now, remember how we said very early on that the testosterone is a cholesterol derivative, therefore it is poorly soluble in plasma, so it has to be carried by sex hormone binding globulins. And this whole concept of sex hormone binding globulins can bind to both androgens and estrogens. However, they have a much stronger affinity and attraction to androgens. Now, and the reason why I bring this up is because an increase in sex hormone binding globulins will lead to more free estrogen. Anything that increases the amount of those proteins, because they have a higher affinity to androgens, they're like, yo, estrogen, you can stay on the side. I'm going to bind to more like testosterone. And this increase in free estrogen means we have more estrogen related effects into the body. So when I say this, if a guy has an increased level of sex hormone binding globulins, they will tend to develop gyno or gynecomastia because the amount of estrogen in the serum increases. And the only reason why I'm bringing this up is not only because it's in your slides, but also because it's very important when we look at some testosterone related diseases. So how do androgens work? And for me, the way how I kind of always remember is that androgens are cholesterol derivatives. They are gonna be similar in function to steroid hormones. Now, if you guys remember from endocrinology, steroid hormones work in a particular way because they're cholesterol, they are able to be absorbed directly into the cell and they will bind to these cytoplasmic receptors. These cytoplasmic receptors are going to basically diffuse right into the nucleus, bind and activate certain gene-like products. And these gene-like products are going to be what allows these androgens to have their effects in the body. Because the way how they work is by increasing the transcription of certain genes. So when we look at the example of testosterone, when it diffuses into a cell, it can either bind into what we call an androgen receptor, then that will go into the nucleus and bind into the gene, or it could basically be converted into dihydrotestosterone, and a similar thing can happen. And they can dimerize within the gene products. Honestly, for me, like the most important thing is knowing this concept of them diffusing into the nucleus and binding and creating like gene transcription products. So what does testosterone do? Now, obviously, like we're very familiar with the doping and the sports related advantages of like testosterone, right? But that's partially just a small segment or aspect of their function. And I want you to kind of, there's a lot of functions, but I want you to kind of lump it into these four big categories, right? The first very important function of testosterone is the formation of the male internal genital tract. That's going to be your epididymis, that's going to be your vas deferens, it's going to be all those internal structures that we spoke about before. Also, by being converted into dihydrotestosterone by 5-alpha reductase, you also have the development of that male external genital tract. That's going to be the penis, that's going to be the scrotum, that's going to be your urethra, that's going to be the prostate. Also, testosterone is very important for those secondary sexual characteristics, having like the deepening of voice, the enlargement of the penis, the male pattern hair growth, the beard growth in the face, like the mustache, etc. Then you have the more common anabolic effects. Testosterone is very important in increasing the strength of bones, which is very interesting, increasing the amount of muscle mass, decreasing the amount of abdominal fat, increasing the amount of RBCs, which explain why testosterone is heavily used by athletes to boost their performance. So that's like testosterone physiology. If anyone has any questions now, let me know. Check. Because now we're going to move on to testosterone diseases and we're actually done. Bloody no questions. I'm just going to move on. So now we move on to like a bunch of different diseases that are related to testosterone. And I'm going to start with something very common. And I just want to bring it up because it's really good to know what happens if you take a lot of external androgens or if you abuse testosterone, for example, if you're taking, exogenous testosterone abuse, right? Now, just to like reorient ourselves with some terminology, exogenous means outside the body. So basically, like doping and taking like testosterone injections. Okay, and endogenous basically means the testosterone is being produced in the body. If someone gets exogenous steroids, that is going to be detected by the body, and you will have inhibition of the body's internal testosterone production because you're getting it from outside. That testosterone, like we said previously, will lead to feedback inhibition at the level of the anterior pituitary and at the level of the hypothalamus. So what happens when someone's taking exogenous steroids? They're going to have a decrease in the LH production because the axis is shutting down. And because you have less LH and less FSH, you'll have a decrease in spermatogenesis. And another effect is an increase in the sex binding hormone globulins. The body is beginning to detect a lot of that free testosterone in the body, in the blood. And it's like, yo, kind of package them into those binding globulins. And remember how we said that they have a high affinity to androgens? So the consequence of this is going to be an increase in the amount of estrogen in the body. So when you look at those people who dope, a lot of the times that decrease in LH will lead to testicular atrophy, right? You are inhibiting the normal function of the testes, so it's gonna get smaller. So they have like very characteristic atrophied testicles, small and very, very hard. Also, there will be a decrease in spermatogenesis. So a lot of times they will have infertility or decrease in sperm counts. And that increase in sex hormone binding globulins will lead to gynecomastia because they have a lot of free estrogen now circulating in the body because those globulins bind more to androgens. Now, whenever we have a testosterone deficiency, we call this hypogonadism. And that's very simple, right? Low levels of testosterone, hypo, because there's low gonadism. But you're going to notice a lot of times it's going to be hypergonadotropic hypogonadism or hypogonadotropic hypogonadism. I distinctly remember, and it's been like 4 years, but I distinctly remember being in class and being absolutely confused. So the secret is in the gonadotropic part. Again, resuming back to the very familiar axis now. Looking at this diagram, right? This is how it works. If the problem is at the level of the hypothalamus, right? Or if that is at the level of the brain, at the level of the anterior pituitary, right? We call this hypogonadotropic. What I mean by this, if your low levels of testosterone is due to low levels of LH or FSH, that is going to be considered as hypogonadotropic. If LH or FSH is low, this is hypogonadotropic because these are our gonadotropins. And we call this by convention secondary hypogonadism. The problem is not at the level of the testes, the problem is a level above. Then we have something called hypergonadotropic hypogonadism, right? Imagine the problem is with the testes themselves, right? The testes simply cannot produce enough testosterone. So what's going to happen is by natural physiology, the hypothalamus will detect that and begin to pump up a lot of LH and FSH. So LH and FSH levels are going to be high. So to recap, if the problem is at the level of the testes, the GnRH will increase to compensate, and we're going to have an increase in the levels of LH or FSH. So we say that this is an example of a hypergonadotropic hypogonadism or primary hypogonadism. If the problem is higher at the level of the thalamus or the level of the anterior pituitary, LH and FSH is going to be low, so it's going to be hypogonadotropic hypogonadism. Now, there's a bunch of different reasons for both. For hypergonadotropic or primary, could be cryptorchidism. The testes are stuck within the abdomen or they never went down to the scrotum. And the problem with this is that the testes need to be cool in order for them to work. So if they're somewhere hot, they're basically not going to work. And you're basically going to have lower levels of testosterone and the body will compensate by increasing the LH and FSH. Other causes of this kind of like primary hypogonadism is stuff like gonadal dysgenesis, enzyme defects, LH receptor defects, or something called Klinefelter syndrome. And then you have hypogonadotropic hypogonadism. Here, examples of that is something called Kallmann syndrome. I'm going to speak about both of these syndromes in a bit. Also, if a patient has a mutation in the GnRH receptor, so basically the anterior pituitary is not detecting GnRH, so it's basically chronically low LH or FSH, or maybe if a patient has a pituitary tumor, or if a patient is taking excess androgens, like we said previously, that is going to be an example of hypogonadotropic via feedback inhibition. Now, what is Klinefelter syndrome? Klinefelter syndrome is known as 47XXY. It's when someone is born having an extra X chromosome. This is an example of a hypergonadotropic hypogonadism, because here the problem is going to be at the level of the testes. That X chromosome, the central pathogenesis of this disease, and I want you to kind of commit this to memory, is dysgenesis of the seminiferous tubules. The problem is at the level of the seminiferous tubules. Therefore, you are basically not able to produce good amounts of testosterone. So the body is going to detect this low level of testosterone and increase LH and FSH, right? That will increase the amount of estrogen, because LH does also, on a side note, increase the amount of estrogen. So these people will present with like very wide-based hips. They're present with gynecomastia. They're gonna have like usually very long legs, because that kind of relates to the concept of like bone growth, because that plays a role. And again, this is a very classic example of hypergonadotropic hypogonadism. You will notice I put an asterisk. Now, I don't know if this error was corrected in your slides or not, this year's slides, but last year's slides have a problem in the slides. They mentioned Klinefelter as an example of hypogonadotropic. That is wrong. In Klinefelter syndrome, you are going to have high levels of LH and high levels of FSH. So the problem is going to be a hypergonadotropic, not hypo. Just something to bear in mind. We also have something called Kallmann syndrome. Now, the central pathogenesis of Kallmann syndrome is a problem in the migration of the neurons in the brain that are responsible for GnRH secretion. And this is an example of a hypogonadotropic hypogonadism. They have a very characteristic appearance. They will present with a delayed puberty and a lack or decreased sense of smell. So these are people who you would expect them to like imagine in clinic you get a 17-year-old guy, but like he sounds like a 9-year-old. He has a very small penis, very small testicles, no hair in his body. That is a good example of someone who does not have enough testosterone to develop these secondary sexual characteristics. And for females, it's very similar. There'll be like a 17 or an 18-year-old girl who is presenting with like 10 stage 1. She has basically no breast development. She has primary amenorrhea. She basically never had a period. So they basically have delayed puberty. And that's because they don't have enough GnRH production. And that is our final checkpoint. Instead of pausing here, I'm just going to keep going, because the rest is just summary slides of what I felt is the highest yield topics. Just to review, this is the structure, the breakdown of male sex differentiation. You begin by having a Y chromosome that allows you to have something called an SRY gene that converts our primitive gonad into the testes instead of becoming the default ovaries. The testes will have Sertoli cells, which will produce anti-Müllerian hormone that will basically go and break down something called the Müllerian duct, which is what gives us the female internal genital tract. So by having these Sertoli cells, you basically prevent the formation of a uterus inside this baby boy. And you also have something called Leydig cells. Sorry, the slide has a mistake. You'll have something called Leydig cells, which will produce testosterone. That testosterone is very important for the formation of the Wolffian duct, which will give us the male internal genital tract. Then you have an enzyme called 5-alpha reductase, which converts testosterone into the more active and potent form of dihydrotestosterone, which will give us that male external genital tract, which will include the penis and the scrotum. This is a reminder or a review of the anatomy of the male reproductive system. You have a testes surrounded by tunica albuginea, and it's filled with the seminiferous tubules that drain into something called the epididymis, which is where the sperm relax and chill and mature. Whenever we want to basically ejaculate, the epididymis will contract and squeeze all that sperm into the vas deferens. The vas deferens will go up and up and up and up and up, and then it's going to meet with the seminal vesicles, right? They will pump a lot of fluid into the sperm allowing us to basically make semen that will contain fructose, which is very important for sperm energy. Will contain something called a vesiculase, which will allow that semen to coagulate upon release. And then the vas efferents will actually become known as the urethra, and it will go right through the prostate. And the prostate will add its own juices, it will add its own things. Then through the prostate, it becomes like now the penile urethra, and it will just go through the penis, through the corpora cavernosa, which contains smooth muscle and is important during contraction, during the emission phase and the ejaculation phase. This is a review of the structure of the seminiferous tubules. As we said early on, the Sertoli cells produce the blood testis barrier, and it's very important because we do not want the blood to mix with sperm, because that will initiate an immune reaction, which we do not want. And you basically have surrounding the seminiferous tubules the Leydig cells, which produce a lot of like testosterone, and that testosterone is going to accumulate within the seminiferous tubules because the Sertoli cells produce these sex hormone binding globulins. This is an example of the whole structure of how the hypothalamus and the generation process kind of like control the reproductive endocrinology. So the hypothalamus secretes GnRH, which goes into the anterior pituitary, which produces the LH and the FSH. The LH goes to the Leydig cell, so L for L, and that will produce testosterone, and the FSH will go to the Sertoli cells and increase the androgen binding globulins. We spoke about how the Leydig cells are very important in the conversion of cholesterol into pregnenolone, which is important for the formation of testosterone. And we know how testosterone can either stay as testosterone or be converted into estrogens or be converted into the active super potent form DHT. And that basically sums it up. Before I move on and start asking you guys questions, I want to know, does anyone here have any questions so far? If there are no questions, then it is my time for me to ask you guys questions. My favorite time. So let me ask you guys a question. Okay. Question.
Wait, there's a question now in the chat.
There's a question in the chat. I missed it. Where is it?
Okay.
I don't see it, by the way.
Oh, she sent it directly. Okay, it says how the congenital adrenal hyperplasia lead to both hypergonadism and hypogonadism.
Sorry, what's the question again?
Basically, how does congenital adrenal hyperplasia lead to both hypergonadism and hypogonadism?
Congenital adrenal hyperplasia, right? That's the disease where we have a deficiency in 21 beta hydroxylase, right? Just to confirm, because it's been a while. The thing with congenital adrenal hyperplasia, and to really answer your question, and I'm gonna come back to you on this just to be on the safe side, but I believe there's different subtypes within, and it depends on which enzyme is affected. In the classic form of congenital adrenal hyperplasia, where the mutation is in 21 beta hydroxylase, the enzyme missing means a lot of those precursors are going to be shunted and shifted towards the production of androgens. So these patients are going to have virilizations. So it's not going to be hypogonadism, it's going to be hypergonadism. However, there is a type of congenital adrenal hyperplasia where the mutation, I think is in 17 alpha hydroxylase, and that mutation leads to low levels of androgens. To really tackle your question, I need to have an image of the different pathway, which I don't have on these slides. So I'll tell you what, message me after the end of the session, and I'm going to show you how different subtypes of CAH, some of them will have hyper, some of them will have hypo, because different enzymes are affected. Some enzymes will lead to too much androgens, some of them will lead to no androgens. That's why we have differences in the picture. Does that kind of make sense?
Yeah, I think it's clear now.
Okay, perfect. So, question time. Question number 1. Which of the following decreases the resistance in the arteries leading to the sinuses of the penis? Is it nitrous oxide? It is activation of the sympathetic nerves innervating the arteries, or is it inhibition of the parasympathetic nerves leading to the arteries? Or is it all of the above? Okay. Okay, nice, nice. I'm seeing a bunch of A's. Anyone disagrees? Damn. Okay. I think it's a unanimous A. And the correct answer is, drum roll, please. Exactly. Nitrous oxide is basically what leads to the increased amount of CGMP within smooth muscle cells. So you have vasodilation. And that's what erection is all about, right? B is wrong because it is the activation of parasympathetic nerves that are innervating these arteries. And C is wrong because no, it's activation of the parasympathetics, not the sympathetics. Very, very good. Question number 2. Blockade of what receptors will prolong the erection of a man? Is it A, phosphodiesterase 5 receptors? Is it B, estrogen receptors? Is it C, muscarinic? Or is it D, cholesterol? Okay, we got another unanimous A. Surely it cannot be A twice. Oh, it is. Phosphodiesterase 5 receptors. Because the whole idea of phosphodiesterase 5 is that it's going to break down testosterone. Sorry, it's going to break down CGMP into something else. And that's basically the whole mechanism of Viagra. The whole point of Viagra is to prolong is to prolong erections, and we do that by inhibiting this enzyme. Now, final question. A 45-year-old man who has 5 children has a vasectomy. As a result, the sperm he produces will no longer be present in which part of his reproductive system? Is it going to be the epididymis? Is it going to be the seminiferous tubules? Is it going to be the ejaculatory ducts? Or is it going to be the vas deferens? Okay. This is very, very nice because we have opposing answers. Some people said C and some people said A. So is anyone willing to be the tiebreaker here and choose an answer choice? We have one vote for A. We have a vote for D. This is really nice. So we have one different answer for all. Anyone want to be a tiebreaker? Oh, okay. We have 2 votes for epididymis. Okay, 2 votes for epididymis. 1 vote. Wait, wait. Okay. So we have 1 vote for epididymis. We have someone. Okay, so someone changed it to C. So we have 2 votes for C. Okay. This is nice. This is a good question. Okay, true. So okay, so this is nice. So listen, I don't know who you are, but like 410 was like she chose or he chose the vas deferens because that's what vasectomy is, right? You're cutting the vas deferens, which is correct. This is true. Vasectomy is cutting the vas deferens. The question is asking here, where will they no longer be sperm? Because here's the thing though, right? And I'm gonna tell you the correct answer right now. The correct answer is actually C. But anyone who chose D is very good. I'll explain to you why A is wrong first, right? Because a vasectomy, you're cutting the vas deferens. All that semen, all that sperm that is being produced at the level of the seminiferous tubules is going to drain into the epididymis. And the epididymis is going to drain through the vas deferens. So technically speaking, the sperm will reach to a certain point the vas deferens until where it gets cut. But it will never reach the ejaculatory ducts because that's where we have a disconnect, you know. So does that make sense why vas deferens is wrong? I think epididymis is wrong. It's clear why. Okay, yes. So so a vasectomy, you're cutting the vas deferens in half, then you're ligating the vas deferens on one side, and you're ligating the vas deferens on the other side, right? Now there is a disconnect between the two systems. So any sperm that is being produced is going to reach up, up, up the vas deferens and then stop at the point where it was connected. So it's still going to be at the level of the vas deferens, proximally, not distally, you know? So the ejaculatory ducts are going to be the only structure where sperm will never ever reach, because we've dissected that part. If I can do something and pull up the give you an example like visually, I think that's better. If I go here, is there a way for me to annotate on like my slides? So
There
this is
should
about,
be. There's like a thing on the bottom left corner.
yeah, I can see it. There's like mouse select.
Yeah, it
Oh,
has like a picture of a or like
okay,
an
perfect.
icon of a marker or something.
Okay, guys,
Yeah.
can you see this? Okay, this is wrong. So this is the vast difference. Okay, can you see my cursor by the way?
Yes.
Okay, imagine I want to do a vasectomy, so I make a cut here. All that semen is gonna, all that sperm is gonna go up, 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 up. It's still within the vas deferens, but it's stopping here, right? It will never reach that there, which is the ejaculatory duct, which is down there, because we've cut it at this stage. So there will be some sperm in the vas deferens in someone who has a vasectomy, but it will never be at the level of the ejaculatory duct. Perfect. And then I just clear and I move on. Okay. Ah, it's phase. Anyway, thank you so much for listening, guys. This was like 2 topics. Hopefully, it didn't drag on for too long. If you guys have any questions left over, or if you have any questions on second year, congratulations, by the way, on making it to first year. If anyone here was with me back in first year, pals, I'm very happy for you. Honestly, making it through past first year is a huge, huge thing. I think that the barrier to making it to second year is amazing. If you had to repeat courses in the summer, do not let that like mess up your mental. Most people, a lot of people repeated blocks during the first year summer. I repeated blocks during that first summer vacation. So don't let that like really get down to you. And if you have any questions regarding this topic, if you have any questions regarding step 1 or step 2, if you have even any questions on my political opinions on like this emerging trend in uni about like the cats, like the garden cats breaking down to smaller gangs and that how it affects the uni relationship with them, I'm always down to open up about that. Seriously speaking, if you have any questions, do let me know. This is like my Twitter account. Most of you guys have my number, so you can just message me there. And for everyone coming on a Thursday evening, thank you so much. By the way, there's a few of you. I really respect that so much. And for the rest of you who are listening to the recordings, thank you for listening to the recordings still. Thank you.